It's always a pleasure bringing you new and interesting episodes of Ladyz Digest, where issues in the world of women are discussed. Ladyz Digest is proudly brought to you by AAU TV, the voice of higher education in Africa. In our previous episodes, we discussed infertility in women, and we brushed over a particular technique, which is the assisted conception technique. And in today's episode, we're going to be treating it in detail. You sure don't want to miss this episode. I'm Joan Ekuya Iyoha. Remember, you can join us on our social media handles at Ladyz Digest on Instagram and Facebook and YouTube at the Association of African Universities. After this time out, we get to meet our guest. Welcome back, and if you're just joining us, this is Ladyz Digest, and we are reaching you live from AAU TV, the voice of higher education in Africa. Before the break, I introduced today's episode as assisted conception technique, and that was what we'll be treating today. And we have in our midst our regular guest, our regular resource person, Dr. Kwejo Owusu-Ansah, to help us digest this issue. Welcome, Doc.
Thank you.
How has your week been?
It was great.
Oh, okay, and we are blessed to
Hope
see
yours
today.
was good too.
Yes, it was good. Thank you. So in our previous episode, just last episode, we talked about infertility in women, and just in passing, you made mention of the assisted conception technique.
Yes.
Yeah. So that's what we'll be treating today. We want to really treat it in detail for our guests to get one or two things from it. So my first question will be this assisted technique. What is it about, and how did it just come about?
Okay.
Yeah.
So assisted conception techniques refers to, is a broad term for a number of interventions,
Okay.
which are aimed at helping the couple to achieve. Specifically, it's aimed at assisting the gametes, one of the gametes or the two. Gametes mean sperm and egg,
Okay.
to achieve pregnancy.
Okay.
So it's a pretty broad topic, but it has several sub-interventions or sub-procedures under it.
Under it, okay. So you mentioned something like different procedures, and also I want to act at this point. So when does it, in terms of infertility, at what point does this become the last option or the only option for a couple?
Okay. So the couple would have had a previous evaluation for infertility.
Yeah.
So and the evaluation is aimed at trying to find out the cause. We will preferably define infertility as failure to achieve a pregnancy after 12 months of regular and protected intercourse.
Okay.
So after that, you seek a doctor's evaluation, and in his evaluation, he's trying to find out, is it a problem with the man, is it a problem with the woman, or both?
Okay.
Now, some parameters or some factors for fertility, let's say age, increasing maternal age, it's a factor. So it's a not so favorable factor for achieving pregnancy, naturally, spontaneously. If you have a very low sperm count, not so a favorable factor. If you do have, maybe you don't have, let's say, a womb because of maybe previous traumatic or previous complications at childbirth, hysterectomy and all that, you will need one of those assisted techniques. So usually the candidates for assisted techniques are unexplained infertility for more than 2 years.
Okay.
Advanced maternal age, 38, 40 and beyond.
Wow.
People who've had their womb or uterus removed because maybe previous postpartum hemorrhage or some other medical problems, yes. So that means that becomes the only option available to you, or very low sperm count, or no sperm at all.
At all. Oh, okay,
yes.
Okay.
So those are the four main. They will outrightly need.
Yeah, the assisted conception technique. Okay. So you mentioned that it's like various. I want to know the different or various approaches to this assisted conception technique. What are the various approaches?
So broadly, we have the IVF. That's the in vitro fertilization.
That I think is common.
And embryo transfer. That's IVF-ET.
Okay.
There's a sub procedure, and I call it ICSI, intracytoplasmic sperm injection, what is reserved for those who have very, very low sperm count. In that case, usually they tend to pick up the good sperm and inject direct into the egg. Then we have the surrogacy. That's either the traditional surrogate, which is not favorably done, but then and more like what we do often is the gestational surrogate, where the surrogate is not related to the baby she's carrying.
Okay.
So that's the more commonly done one. So those are the main broad ones. But still an evolving field anyway. Other procedures are being added on, but the three main broad ones.
Oh, okay. So can you walk us through a procedure? For instance, a lady comes to your office and opts for one of the techniques or opts for an assisted conception technique. Can you just walk us through maybe the procedures from the interrogation to the process itself?
So usually a lady will walk in with a desire to wanting to conceive.
Sure.
And we prefer the first evaluation done with the male partner.
Okay.
So we come in person with the male partner, we evaluate. In the evaluation, we are trying to find out what the cause of infertility may be. But if we get to the point where we realize that, okay, one of these things I mentioned earlier is the reason, maybe she's like 42, wants a child. Because of declining ovarian reserve at 42, increased risk 42. Of abnormalities, chromosomal anomalies of the pregnancy, if she uses her own egg, or even increased risk of miscarriage.
Sure.
It would be a better option to use an IVF approach or assisted conception approach, using, let's say, a donor egg with consent.
And donor egg?
Egg.
Okay, what's that about?
So what that means is that we will take an egg for a younger woman. The peak of fertility in women is between 20 and 24.
Sure.
So take the egg for a younger woman, maybe 18, 25, and then screen her medically, counsel her psychologically, and then stimulate her and take her eggs with consent, and then use her partner's sperm to fertilize it.
Wow. And
then transfer into her womb. That's in the man and the woman, the her womb. So she gets pregnant, carries the baby to term, and delivers the baby.
Wow. Yeah. Wow. Okay. Wow. I think, okay, that's cool. Because I remember then, I don't know, okay, when I was in SHS then, and I know we usually laugh at some people and tell them they are test tube babies. Yeah. How is that done?
Oh,
yeah.
that's the informal term of test tube baby.
Okay.
Usually because of the way it came about. I think the first IVF baby was born in 1978 in July.
Wow. In
London, where that was where the term test tube became. There have been several other, probably about 4 million babies born after that by the same technique. Yes. Yeah. So there's this perception that probably the babies might not be all okay. That's why people can make fun of these people with that thing. But then that's not entirely true.
It's just a perception. Okay. So where are there times that this assisted conception technique, I won't say can go wrong, isn't or won't be successful? And if there are, what would be the reasons or the factors?
Well, yes, it's not 100% successful. It's probably depending on what approach you are using, what technique you involve. We are looking at probably from 35 to probably sometimes at most 70% success rate. Yeah. Okay. And then it depends on factors making it fail. Will depend on one, the quality of the embryo.
Okay.
How well prepared the woman's womb was before the embryos were transferred. Even the transfer technique. So maybe the technical people involved.
Yeah.
Or even the cultures and all that. There are several, but you can't always find out why it failed. Some you can tell, some you can't.
You can't tell. Oh, okay.
And sometimes even the very transition of leaving the lab into the woman's womb, some embryos may not survive.
Wow. I think it's one, the movement, and two, there are two different conditions.
So it's very difficult to put a finger in all cases on why some failed.
Oh, okay. Okay, so you mentioned surrogacy as
Yes.
as one of the interventions for the ACT Act, yeah, assisted conception technique. Can you walk us through that, or just give a brief explanation of that?
Okay, so well, the surrogacy, as I mentioned earlier, there are two kinds: the traditional and the gestational. What we tend to do in the IVF is gestational, where the woman sort of hide in a way to carry the baby for a couple. Now, what happens is that usually you have a woman who, either due to medical conditions, either maternal medical conditions, or maybe problems with her womb, either being absent or some other problem, is being declared not capable or not conducive to carry a pregnancy on her own. So she would need someone else to do that for her. So usually, in some people, their eggs are viable, so you take their eggs, partner's sperm, and they add it, form the embryo, and put it in another person's womb.
Just to carry.
Just to carry.
Okay. Okay.
Some cases, it's not even her egg; it's another person's egg. But usually, gestational surrogates are not related genetically to the baby they are carrying.
Oh, okay. Okay.
In order to minimize conflicts and emotional attachments. Yeah.
Okay, so is it a rule, or is it like, should I say a rule that compulsory that a surrogate mother must be somebody unknown? Can I or can someone decide to volunteer to be a surrogate for maybe a friend or a relation? Is it allowed?
Oh yes, it's allowed. It can be done. We on this side all tend to try and discourage that. Because we don't want a scenario where somebody might come back want to lay claim to the child. But that said and done, every person who does this, either surrogate or donor, undergoes adequate counseling to understand what you are getting into and their responsibilities, their risks, as well as what their rights are and what they cannot have in terms of their limitations or prohibitions. Yeah. So yes, you can do that. And then, because in other jurisdictions, some mothers carry for their daughters.
Yeah, I think I've seen something like that.
It can be done. But whoever is done is counseled, and usually there are documents signed to this effect.
Agreements, that's what
so
it
covers it.
To avoid any future. Okay, so let's talk about some risk that might be associated with this technique. I would want to think that maybe because it's not normal or it's not natural, let's say natural, it's not natural, there may be some risk, maybe birth defects or maternal defects. Are there any risks associated different from the normal pregnancy risk?
Well, the risks are mildly or slightly higher than the natural.
Okay.
But it's not any outstanding risk.
Okay.
The reason is that it's usually your own egg, your own sperm, that forms a new embryo. It's actually your baby. The only thing that is unnatural is the initial environment you grow up in for the first few days before they get transferred. That's the only thing that's unnatural. Okay. But aside that, everything else is. So there's a small risk of usually miscarriage, usually highest within the first 12 weeks, 13 weeks, thereabouts. And then usually after that time, the rest of the pregnancy proceeds normally as every other pregnancy. The other bit is in other places where they do multiple embryo transfer, where more than one embryos or babies are placed in there. You do have, if all takes, you do have multiple pregnancy to deal with, where there's potential complications for mother and baby, increased risk of preterm labor, increased risk of preterm delivery, growth restriction or prematurity for the babies as well. Maternal anemia, all the complications that come with multiple pregnancy can come if that was what was done.
Okay.
But then on the whole, it's a marginal something.
Okay. If you just joined us, this is still Ladyz Digest, and you can catch us up on our social media handles on Facebook and YouTube at the Association of African Universities, and our Instagram handle at Ladyz Digest. We'll be back. Welcome back from the quick break, and we are discussing the assisted conception technique with Dr. Kweju Owusu-Ansah. Welcome back, Doc.
Thank you.
Yeah, so before the break, you mentioned, you talked about the multiple pregnancies, conceptions, and births. And funny enough, that was supposed to be my next question. Okay. This is my personal view. From observations or hearsay, it seems this assisted conception technique, or let's just say the IVF, produces multiple births. I don't know if it's my own thoughts, if it's a myth or a fact, so I want clarification on that. Because most times when, especially ladies who are above 40 or so, and they give birth, it's usually more than one. There are usually three, there are 2, 3, thereabouts. But you made mention of the fact that if they make it multiple, so I want to know if it's intentional or the act alone just makes it produces multiple.
Well, it depends. It depends on what intervention they are using. If you are using just simple, the drugs that are used, some medications, some injections, will develop more than one follicle, or quote unquote an egg, at the same time. Naturally, the ovary will select one at a time. That's the natural.
Okay.
Once you use those medications, so there's some risk, probably up to 8–10% risk of having a more than one egg being released, so multiple fertilizations and then multiple pregnancy. Now, if you are doing the full-blown IVF where everything is done, fertilized in the lab and transferred in the womb, generally in our jurisdiction, the gradual shift now is to do what we call a single embryo transfer.
Okay. So
you take one embryo, even have a number of them ready to go. You take one good one, analyze, make sure genetic makeup, everything is fine, then transfer that single one. Because it's usually the multiple pregnancies are usually seen as a complication of the procedure. Okay. In our part of the world, but that is where you have a very sophisticated IVF setup. Okay. Where you can tell that one embryo you're placing is 100% genetically correct and everything looks good. Even though it can still fail. Okay. In our part of the world, a lot of factors, we do not do single embryo transfer as yet in most centers. And that's partly due to multiple factors. First of all, multiple pregnancy in its natural incidences is more common on our side than the West. Okay, I think. So in terms of competencies or getting you, we are quite familiar and conversant with it. That aside, culturally, there's love for babies. More than one, more than 2, 3. It is not something that will raise eyebrows on our side. Sure. Okay. So that is the, and then thirdly, given the financial implications of the procedure, most people, couples, you can't realize that, oh, they want more, because most of them would have been waiting for years. Yeah. There's cultural, societal pressure on them. Exactly. And then given the financial thing involved, they think, why can't I get all at a go than, so you don't come back, yeah. So the couples also tend to lean towards that, yes. So that is made us, so where you have more than one embryo being placed, which is happening a lot in our side, if it's available, more than one will be placed, maybe 2, at most 4. Okay. You're likely to get a chance of a multiple pregnancy, and it's associated complications. Yeah. And it's because definitely there will be the associated complications. Oh, okay. Because I think it's because for, let's say, for a 45-year-old lady who has opted for that, instead of coming back for the same procedure, you just do it once and get at least 2 or 3, and you are done. That's true. So let's talk about the acceptance, the perception. Drawing far back from where it's coming from, you said 1979 or so. 8, okay. Yeah. So it's almost 42 years old. Imagine. Okay. So that the baby is 42 years to the first successful one. Oh. But there's a history before 78. I see. As far back as 50s and 60s, people were trying. So it took over 100 attempts before the first successful baby.
Which was 40.
Was made in 1978.
Wow, 42
so
years.
42 years since the first successful baby.
Successful baby, okay. How has the, how would you say personally, has the perception changed and the acceptance, and want to just narrow it down to Africa and even Ghana, because we don't know how it is in other countries. Let's say Ghana, how do you see the acceptance and the perception change?
Well, what I've seen from my experience is that yes, most couples come in not too sure or not too aware of such procedures.
Sure.
Okay, they come in with a simple request: we want to conceive.
Yeah.
After X number of years of trying, but then along the way, depending on what parameters or their situation is, you realize that this might be the best pathway for them. So you start the counseling along those lines. Yes, most will go along with you because they want the child. Yeah. Usually the biggest barrier is the financial bit of it. But after they cross that part, yes. In terms of acceptance, they've been wanting children for long, so they are more open to the idea of acceptance. Yeah. What I've noticed is that culturally they tend not to disclose or say much about the fact that they did this procedure to have their babies.
Oh, okay. As in open up.
As I open up about the details to the society and maybe that's what I've realized. And I think that's because culturally we still have a lot of, I don't say misconceptions, but a lot of perceptions in society where even something as simple as a mode of delivery, whether it was C-section or vaginal, it's seen as, oh, you're not woman enough.
If you don't push.
Exactly. So I kind of see why they tend not to be very open with their friends or my relatives about the exact details. That's what I've realized. And that's culture. Probably people may not react to it.
That's true.
So I've seen a lot of people who do the procedure. They are silent to the procedure, but they'll show you their product. Oh, I got that delivered. And that's it. And it sort of goes to tell you that, oh, you thought I couldn't make it,
I've made it. That is
and
all.
they leave it at that.
But how I made it.
Exactly. They are silent on that side.
Oh, okay. Well, but I don't think it should be, because they are still babies. They are still human beings.
Well, yes, but it's I know. I understand where they're coming from. Our culture is very quite sometimes tough to navigate.
It's true, the culture. We are still a bit back with that in that aspect. Okay, so let's talk about some challenges. I don't know if there will be some challenges that you practitioners face with this technique. So here we are talking about from the patients to any other reason that, any other challenge you face in this procedure from the beginning till it's successful.
Okay, usually the challenges will be from the patient itself, the evaluation and the workup. Usually I would have somebody who's probably been around other places, had 1 or 2 other interventions done, may have 1 or 2 complications in the process, may have had previous surgeries for other gynecological like fibroids or endometriosis, other procedures done. Some do come who are quite advanced maternal, maybe 40 and you may have coexisting medical problems, let's say diabetes, hypertension, thyroid disease, which are not so well controlled, or they don't even know they had that. Which might have been a contributing factor to infertility.
So that has to be treated.
So those are the initial challenges. Then you have to optimize the woman, and then sometimes you do a semen analysis and it's not good enough. You have to optimize the man too as well. So those are the initial challenges. So it's getting them ready. So once they are ready and the procedure goes on, usually the rest should go on successful. Occasionally you will get complications from side effect or the medications, the injections, because of the hyperstimulation syndrome where they'll get bloated, they'll get a bit of fluid retention and all that from the side effects of the injections we use.
And I don't know how true, just one clarification, that diabetes is very common. I don't know if it's related to the bloatedness. Is diabetes really very, very common with this process for the ladies? I know it's quite common with every pregnant.
Oh, well, you see, yes, what happens is that if she does get pregnant, you're likely to have a woman who is advanced in age, who is now pregnant, probably for the first time. So a first-time mother, advanced maternal age, had an IVF procedure, automatically that's a high-risk pregnancy.
Yeah.
Even before any other thing comes in.
Exactly. That's true.
So that's also, because of the age, you might find a woman who's probably either maybe a very early onset of diabetes or some early onset or some other medical problem. That probably was there, but probably might be accelerated by being pregnant.
Yeah.
So,
that should be okay. So let's talk about we're almost wrapping up. Let's talk about evaluation of the patient. So the lady has given birth successfully. Are there any special, should I say, special follow-up procedures or evaluations done for a lady who goes through this process? So it's just the normal postnatal doctor treatment?
Well, it depends on how the pregnancy plays out. If she usually will take it trimester by trimester. Once you cross 13 weeks, a very small percentage of having a miscarriage or pregnancy will likely to go on to the end. So we get to the end of it, maybe around 20 weeks, we do a scan to see that baby is normal. So all fetal or structural structural organs are assessed. And then we are sure that, we can get it sorted out. So that's then said. We can also do other maternal evaluations. Let's say for blood sugar, every antenatal visit, blood pressure check, and all that. If the pregnancy remains uneventful, no complication whatsoever for mother and baby, after delivery, it's usually regular postnatal follow-up. For the mother, you might do a bit of an extended, maybe a couple of months after, because of the age and the fact she got pregnant. I sometimes tend to see them for as long as maybe a year.
Wow.
Depending on what the issues that was there before and after, or during pregnancy as well. So it's a case-by-case thing. But then usually if it goes normal, if let's say she's a young group, let's say 30s or 20s, has IVF, goes through everything, baby is fine, mother is fine, no complication developed whatsoever, it follows regular follow-up schedule.
So this is quite a weird question, but is there a possibility that after a lady does let's say the IVF for a first conception, is there a possibility that she can conceive naturally whatsoever?
Oh yes, it happens. It depends on what the parameters before the IVF was done were. Some can be modified or fixed. Let's say if her woman was fine, and the only issue was the male factor, where the sperm count was low. And then maybe treatment was very slow, or you could do the IVF process, and then I've had several like that after that. You do the IVF and then spontaneous conception happens afterwards.
Wow. So it's possible, just depending on the condition and the parameters.
But if it's an advanced one, let's say 45, it's not likely spontaneous will happen.
Or if maybe there is no womb or anything, there is no possibility. So this is our last question, and this is personal. We are wrapping up, and you furthered your training for let me read. You obtained a fellowship in assisted reproductive techniques in India, and you have since successfully helped several women achieve their dreams of becoming mothers through these various techniques. And the oldest being a 59-year-old woman. So my question will be, what informed your decision to even venture into that aspect of medicine, and also how has the experience been, especially that particular case?
Well, so experience medicine, gynecology or infertility?
Infertility, specializing in that.
I think it comes with residency training, postgraduate training, where you realize as you go through the different fields of obs and gynae, you realize that there are certain things that come easy, certain things that are difficult. I found infertility challenging, you know, and then I found myself maybe inadvertently or unexpectedly in a fertility center.
Okay.
Assisting some other senior colleagues, and then things changed such that I had to be sort of stepping.
Yeah.
You know, so I realized that all of a sudden I was flooded with a lot of cases, you know. So I think that exposure started slowly turning my interest in that way.
Oh, okay.
So I followed up in that pathway and finally decided to go train on it.
Okay,
yeah.
And how has the experience been so far?
It was very interesting. Very interesting. There are disappointing days, there are very exciting days too, you know. But sometimes unpredictable, in spite of best efforts and intentions. The outcomes are unpredictable. And sometimes you are caught in the middle. The people would feel, oh, you let them down. But it's a science, and the science is not 100% perfect,
sure,
unfortunately. So it's, you know, we have our moments, good days and bad days.
Bad days, yeah.
But with that particular case, that said and done, we do not encourage IVF beyond 50. Oh.
You do not encourage it?
No, as a general rule, don't encourage it because of chance that it might not even work.
Okay.
And then they might have coexisting medical problems that might make issues complicated.
Very complicated.
Yes.
Yeah.
So we tend not to. You know, but she was a different case.
Wow.
That I think, I don't know why, but then she went around. A lot of fellow colleagues decided not to try because of obvious rules and everything, you know. But the whole lot of talking to, I said, fine, let's see what. And so she would bear my, I did a whole regular screening at every turn to the end, yes. Because I didn't want any complication to come. Sure. She was hypertensive, by the way. Wow. But that was the only problem she had, you know. And yes, multiple attempts. It didn't come on the first time.
Oh, multiple attempts.
I think 2 or 3 times. Wow. But it worked.
Wow.
So she's 60 now with a 1-year child.
This is lovely.
But sometimes that's what we don't tend to do, because if I project, I'm looking at, she'll be 70 and that child
will be 10. No, so
10. You know, so over like time you realize that, okay, it may not be the best idea to do. But other jurisdictions like Asia, India, they've done 60-something-year-old. Oh, even I think Nigeria has had some advanced, pretty advanced, you know. People are trying to outdo each other with that. But
I see.
It's just not recommended
it's
to
not,
do.
It's quite risky, yeah.
Exactly, because it's aside the risk, you're looking at the child.
Exactly.
You have a child to very advanced aged parents.
Yeah.
You know.
It's true. Losing, well, maybe she has made some, she might have put some things in place.
Those are the issues, you know, so it's more like a moral, ethical
50-50
sort of thing.
But I think she will really be grateful. She'll be really grateful.
Yes. She'll be very grateful. But I'm not too sure I want to repeat that.
You wouldn't want to repeat it?
I don't know. It's still a debate.
but it's good. At least I know you feel good, like as in achieved that you've
some
tried
sense
something.
of accomplishment. Yes. Because of the that is the persistent paid off. But I think that maybe we'll debate again if we want to do that.
Okay, thank you for joining us on Ladyz Digest. And we hope to see you some other time. This has been Ladyz Digest, and many thanks to my production team for making this production a very successful one. Till I come your way next time, I'm Johnny Queer. You are to stay tuned.